Minorities remain underrepresented in cancer clinical trials for a variety of reasons. One is just low levels of knowledge and awareness. Mistrust is still an issue of not only researchers, but also the healthcare system as well. And then still from at an institutional and systems level, there's just not a robust infrastructure that allows for minorities to participate in cancer clinical trials where most of them are treated. That's in community oncology settings and/or safety net hospitals. And so it's a confluence of reasons in terms of why we do not see greater representation. But I think if you go where the individuals are being treated, then the likelihood that they may participate may increase. You have this mistrust that remains. Their participation is very much is needed for external as well as internal threats to validity. And so today's medicine is yesterday's research. And so our medicine and our medical enterprise is only as good as those who participated in helping generate the data that helps drive medicine, especially from a therapeutic standpoint. So to have the participation of minorities will ensure that we're able to best deliver quality care to the individual. Yeah, so we're starting to see more and more of these technological tools, if you will, applied across a cancer continuum in the context of prevention, screening and early detection, diagnosis, treatment, and even more recently in early and late stage phases of survivorship. And so I think the tools could help bridge the gap where we have some deficits as relates to physicians or researchers or other medical healthcare providers that may not have the bandwidth to see as many patients as needed, or healthcare systems that may not have a robust infrastructure for routine monitoring and surveillance, as well as other health activities. I think these tools could potentially get us there. We're seeing more and more of an application of biometry, wearable technologies now that again helps continue monitoring of the individual to really bring in those other factors that we discussed in my talk as relates to contributing to cancer disparities, such as culture, such as behavior, and so just to name a few, I know some studies are now looking at this whole role of photojournalism, right, where you're actually taking a snapshot of what you eat 3 times a day and then sending that to your healthcare provider and then having a conversation about your diet. And so, these are all things now, a bit invasive, right? And I mean, that level of transparency, do we want that to be known? But I think these tools could help get us there, or help at least enhance our understanding as it relates to some of these causal factors related to disparities. Yeah, so really work with funded research investigators. That information is publicly available. They can go into the National Institutes of Health Reporter or NIH Reporter. You can put in your topic of interest, and it will populate a listing of individuals who may actually have funding to research a particular topic, such as prostate cancer or breast cancer, whether it's breast cancer prevention or prostate cancer prevention or lung cancer prevention or even lung cancer treatment. But then not only NIH Reporter, but you also have PubMed, which is a repository of scientific articles that mostly have been generated with taxpayer-funded dollars. And so again, I would utilize those 2 sources as a starting place, but then send an email to those individuals, the first author on the paper or the senior author on the paper, or the principal investigator, the one who's actually running that study. And then find out what they're interested in, find out what they're investigating, find out what they've been funded to do, and then ask them for their response and their onus to disseminate their findings. Now it's a mandate that all research findings funded by the National Institutes of Health have to be disseminated back to the target population that was included in the study. And so it's good science, and it's ethical science as well.